Yeah. Good evening, one and all. It's my pleasure to invite you today for the ICOG webinar, Academics and Perspectives, which is in association with the Tamil Nadu Societies of Trichy, Vellore, Tanjavur, Virudhunagar, Kanjipuram, and Dindigul. Today we have three very important sessions. One is Know Your ICOG by Parag Binivale sir, our chairperson elect of ICOG. And we have another talk on hyperprolactinemia by Dr. Raki Singh and biomarkers of adverse pregnancy outcomes by Dr. Manisha Beck. I would like to begin by thanking Parag sir for bringing us this program. And this program is convened by Dr. Charmila ma'am, Vice President of FOXY. Can I have the slides, please? Yes, Dr. Parag Binivale, who's the senior consultant of obstetrics and gynecology in Pune, and he's a chairperson elect of ICOG and past president Pune Obstetric and Gynecological Society, and also he was a past president of Menopausal Society of Pune and a national website editor of FOXY.
Yeah, thank
and
you, Madhu.
reviewer of Joggy.
Yeah.
Yes, sir. So it's my pleasure to introduce Charmila ma'am, who's the Vice President of FOXY and Vice President of Trichy Obstetric and Gynecological Society. And she was the past chairperson of Clinical Research Committee of FOXY. And she's a ICOG Governing Council member. Request ma'am to give the welcome address.
Thank you, Madhu. Thank you so much for that wonderful coordination you have done. For the part, this is the third part of the series which you're doing for Tamil Nadu societies. It is entirely due to the hard work and motivation by the office bearers, especially Dr. Parag, Dr. Parul Kotadwala, and Dr. Sarita. And it's a heartening moment to see Dr. Lakshmi Shrikande, madam, joining us today. She has done such great work in the past year in ICOG, and which was continued during this year also. And I would like to welcome all the speakers for today, Dr. Parag, Dr. Raki Singh, and Dr. Manisha Beck, as well as the chairpersons, Dr. Pratik Tambe, Dr. Tamil Chelvi, Dr. Tamil Mani, Dr. Chakravarti, Dr. Uma Mageshwari, Dr. Amala Devi Madam, Dr. Umayal Murugesan, and Dr. Uma Vel Murugan. The talks today, we have chosen our talk on endocrinology and the other in obstetrics. We've got two eminent speakers other than Dr. Parag. Dr. Parag will be talking about ICOG academic activities. This program has been especially formulated so that the youngsters in Tamil Nadu societies know about the ICOG activities, because most of them are quite oblivious sitting in their practice. And then when a problem creeps in, then they start asking for further information. I think we need to update ourselves with the academic activities, and such wonderful programs have been conducted by all the chairpersons. And I know that Dr. Parag has got a beautiful program for next year. So whatever the link comes, we request that all of you join and attend the academics and interact also, so that you get to learn sitting in your own place. It's not necessary that you need to travel and get information nowadays. After COVID, got a wonderful platform and which is virtual, and we learn so much. And I think we should utilize that opportunity. I would like to thank Dr. Parag for the opportunity for conducting this program. It's a very, very unique initiative. Thank you so much, Dr. Parag. And special thanks to Dr. Madhu also. She has coordinated all the programs, has taken so much of pains to make sure that all of you attend. And special welcome to both Dr. Raki Singh and Dr. Manisha Beck. Dr. Manisha is the president of the Vellore Society. He's from CMC Vellore, and they do such great research activity. And I thought she's one of the best persons to talk to us about the newer versions of whatever's happening in obstetrics. Thank you, Manisha, for sparing your valuable time, as well as to Dr. Raki Singh, who's from the North Zone, but she always has been one of the best chairpersons of FOXY when she was chairing the endocrinology committee. I'd like to thank Dr. Raki also for joining us today. May I request Madhu to start the academic program, please.
So, Nirima, can I have the slides, please? Moving on to the first session. Yes, we'll go on to the first session, chairpersons of the first session, yes. So, for the first session, we have our three eminent chairpersons, Dr. Pratik Tambe, who's a consultant ART specialist and endoscopic surgeon at Mumbai. He is a governing council member of ICOG and also governing council member of Indian College of Reproductive Medicine. and the managing committee member of ISAR and managing committee member of Maharashtra chapter of ISAR also. He's a past chairperson of Foxy Endocrinology Committee, and he's contributed numerous books and chapters, and he's an eminent faculty in various conferences. And we have our next chairperson, Dr. Tamil Shelvi, who's the president of Trichy Obstetric and Gynecological Society, and she's a consultant at Arul Hospital, Trichy. Next slide, please. Our next chairperson is Dr. Tamil Mani, who's the president of Tanjavur Society. We have Parag sir and Tamil Chelvi ma'am with us today. Request you to please introduce Parag sir, ma'am.
Madhu, 1 second. I just forgot to welcome all the presidents and secretaries of all the 6 societies: Trichy Society, Dr. Tamil Chelvi and Dr. Uma Velmurugan; Velu Society, Dr. Manisha and Dr. Swati; Tanjavur, Dr. Tamil Mani Madam and Dr. Uma Brinda; Virudhunagar Society, I think they have joined today. I think the president secretary have not come.
Ma'am, not yet joined.
Kanjipuram Society, Dr. Chakravarti sir and Dr. Umayal Murugesan, as well as Dindikal Society, Dr. Amala and Dr. Svetika. Yeah.
No, ma'am. Dindikal is.
Dindikal, she has joined.
Selvarani, ma'am.
Selvarani. Okay.
Yes.
Dr. Selvarani, would like to welcome all of them, as well as a special welcome to Dr. Shobha Gudi, who has joined all our programs. Every program she has joined. Thank you so much, madam, for joining us. Please introduce Parag,
Yes.
Dr. Tamil Chelvi.
Tamil Chelvi, ma'am.
I am very privileged to introduce Dr. Parag. Parag doesn't need any introduction, and such a vibrant personality, and PG teacher in Kamala Nehru Hospital, and chairperson elect ICOG 2024, and president Pune OG Society, vice chairperson ICOG 21 to 23. And he is very well known in Pune Menopause Society and secretary of ICOG and so many things. And apart from that, I know Parag is a very, very, very nice person by heart, and he is interested in teaching. And we like to know many things, what ICOG does to the OB-GYNs of our country. Over to Parag.
Yeah, thank you, Tamil Chelvi. It's a pleasure to see you after a very long time.
Very long time.
Yes. Good evening. I bring greetings from ICOG, and on behalf of all the office bearers of ICOG, welcome to this program or this session of academics and perspectives. This is a small attempt to reach out to smaller societies in the country. This is the 3rd program for the Tamil Nadu societies, and I must appreciate efforts put in by our governing council member, Dr. Charmila, and young dynamic Dr. Madhumita, who made this possible. And I welcome Dr. Lakshmi Srikhande, immediate past chairperson of ICOG, and 3 of my very, very enthusiastic governing council members, Dr. Shobha Gudi, Dr. Rakhi Singh, and Dr. Pratik Tambe. In fact, they are the ones who are going to plan this activity in their states in the near future. So Shobha, Rakhi, and Pratik, this is the standard format that we've been following, and we will have more and more reach out programs with the societies. I must thank the president of Foxy, Dr. Jaideep Tank, the chairperson of ICOG, Dr. Parul Kotadawala, Dr. Sheila Mane, the vice chairperson, and Dr. Sarita, the secretary, for allowing me to initiate this program. And when I discussed this with the governing council members, they were more than happy to take this ahead. Thank you to all the Tamil Nadu societies who've joined today: Trichy, Vellore, Tanjavur, Virudhunagar, Kanjivaram, and Dindikul. Thank you all the presidents and secretaries for joining hands with ICOG. In next 15 minutes, I'm just going to talk about what ICOG is doing and how you can become a fellow, how you can participate in all ICOG activities. So the Indian College of Obstetricians and Gynecologists was established almost 40 years ago at the 28th All India Conference at Durgapur in West Bengal. And currently, we have over 2,400 fellows and nearly 182 members of ICOG who are doing a lot of clinical and academic activities all through the country. The mission with which the ICOG was established, with an aim and objective of promoting education, training, research, and spread of knowledge in the field of obstetrics, gynecology, reproductive health, family welfare, and related areas. The vision of ICOG is to strive for advancements of standards of education and quality healthcare practices throughout India, and the college encourages safe, ethical obstetric and gynecological practice with an aim to benefit the women of our country. I pay my respects to all the past chairpersons who have brought ICOG to where it is today. And this is the team ICOG 2024. And I must appreciate the efforts put in by all my 25 governing council members, and the same team remains with me next year to carry out all the activities of ICOG. So a big thank you to all of them. Right. The first thing I'm going to talk about is the ICOG credit points, and I'll tell you why these credit points are important. We all are aware about various credit points because for all our medical councils do give us credit points. These ICOG credit points are special for us because they will help you to get the fellowship of ICOG if you collect about 100 credit points over a span of about 3 years. So all FOXY affiliated societies, all FOXY committees, state level OBGYN associations, all medical colleges, and other organizations like RCOG, FIGO, SAFOG, AOFOG will get ICOG credit points without any charges. For a 2-hour program, we give 1 credit point. For a half-day program, we give 2, and for a full-day program, we do give 5. And of course, if there is international faculty, we add 1 credit point. Of course, other organizations which are not associated with FOXY can avail these credit points against a small payment. ICOG invites application from various FOXY societies to host ICOG CMEs, and these are 1-day or 2-day CME, and we encourage various societies to have these CMEs. We can allot 20 such CMEs throughout the year, and there is a small funding from ICOG provided for these programs, 25,000 for a 1-day program and 50,000 for a 2-day program. So if any of the society presidents and secretaries are interested in applying, do visit the ICOG website. There's a form. You can go through the form and submit it online. The ICOG certificate courses, the training courses are something which are really very, very interesting. And there are 42 centers across the country. There are quite a few in Tamil Nadu who are imparting knowledge about reproductive medicine. There are 28 centers training our young freshly graduated doctors in gynae endoscopy. 13 centers are there for fetal medicine, vaginal surgery, critical care obstetrics, and ultrasound are the other courses which are run by the ICOG. And now, along with the 6 months training centers, we are offering fellowship courses of 1 year, and then there are some centers who have opted for it. The fellowship course was started with the ART law in mind, because we want all our young colleagues who are interested, especially in reproductive medicine, to be protected under the purview of ART law as far as the training is concerned. For last 3 years plus, we are conducting ICOG centralized lecture series, and this is basically meant for trainees who are undergoing training in reproductive medicine, in gynecological endoscopy, and in fetal medicine. Now, we do have 2 sessions every week for reproductive medicine, and I'm happy to have Dr. Pratik Tambe, who's the convener of this training program, and he will continue to do so next year as well. ICOG online courses lecture series for gynecological endoscopy. It is coordinated by Dr. Dinesh, Renu Singh, Mala, and Subhash. And Chinmay, Vandana, Bela, and Pragya are the ones who are moderating the fetal medicine training courses. These are meant for the trainees, but other youngsters who wish to join these programs, they can contact the ICOG office, and they can certainly join this program against a small payment. This is in nutshell the program we have. It covers the entire spectrum of that particular subspecialty, like reproductive medicine or gynae endoscopy or even fetal medicine. And all we want is to the young trainees who are taking these training programs should be exposed to all other senior faculty all across the country. For years, ICOG is now known for its web series. So we have ICOG PG Gurukul, which is there on alternate Wednesdays, twice a month. This is coordinated by Dr. Alpesh, Dr. Harish, Ashwath, and Kiran Pandey. Foxy ICOG Jogi Research Methodology and Journal Club. We have webinars on family planning, which are coordinated by Dr. Shobha Gudi. The ICOG Masterclass which is there once a month, and we intend to have more of such programs probably every week. The ICOG Foxy PG Clinic, which is there on the second Sunday of every month, is one such popular program which is coordinated by Dr. Ashok Kumar, who will be the vice chairman with me, Dr. Hafizur, our governing council member, and Dr. Ashish Mukhopadhyay. ICOG online certificate courses, which are something which all of us as office bearers and governing council members look forward to, because this is a 3-day extensive teaching program or training program attended by a lot of OBGYNs all across the country, which focuses on a particular topic, and we expect them to attend these 3-day of course. There is a pre-test and post-test which we expect the delegates to attempt, and then if they get more than 50% mark in all these all 3 days, and they do get a certificate from ICOG. And this year we've started ICOG New Frontiers, which is convened by Dr. Sarita Balarao, who's the secretary. Every year during the AICOG, the second day afternoon is dedicated to the Foxy ICOG Dr. C.L. Javeri Endowment Symposium. Dr. C.L. Javeri was the founder chairman of ICOG, and we do select 5 speakers who have contributed to ICOG. So they have to be fellows and they have contributed to the working of ICOG. The topics are related to the current official theme, and we do select such 5 senior speakers who are given 15 minutes to speak on their topic. The ICOG Dr. C.S. Don oration is named after the second chairman of ICOG, late Dr. C.S. Don, and this oration is given during the ICOG conference, and it is delivered by the immediate past chairperson of ICOG. Dr. Usha Saraiya, who was the 4th or the 5th chairman of ICOG, contributed generously to start this oration, that is Foxy ICOG Dr. Usha Saraiya oration, and this is on a special subject of gynecology. It is meant for all the fellows, so all the fellows who are working in the field of gynecology can.
Is not going to live with it. That is the final conclusion.
I think there's some noise. Can the person be muted, please? Right, and then now one important thing all of us must remember is all the societies who are sitting here, they can host this particular oration. The orator is decided by the office bearers after they submit an abstract and the contribution in that subject. We of course respect seniority, and the selection is made in the governing council. And of course, the societies can also opt for hosting this particular oration. Professor Krishnendu Gupta was also a chairman of ICOG, and this oration was started in 2018, and it is delivered generally by the sitting Foxy president on subject of women's health. So it is the Foxy ICOG Professor Krishnendu Gupta conference oration on women's health, It is organized every year during the ICOG annual conference. The latest oration to be started, and this is thanks to Dr. Lakshmi Shrikhande, who's joined us today. And this is called ICOG RRR oration, and it was generously donated by the organizing team from Nagpur, led by Dr. Lakshmi Shrikhande. This is the oration delivered by the sitting chairperson on the presidential theme during the ICOG conference. ICOG encourages two visiting or traveling professorships, and these are funded by ICOG. We expect senior professors to visit about 3 days in the OBGYN department of a medical college. So again, an opportunity for the societies who are with us today. They can host a professor for about 3 days. They can always have ICOG CME when the professor is in town. And we do contribute in the form of taking care of the travel of the visiting professor. For the youngsters, this is one of the ICOG scholarships given every year to encourage young OBGYN, and they can attend any of these training programs wherever they wish to. So it is for about 2 to 4 weeks anywhere in India, and it is supported by ICOG. So there are so many benefits of becoming ICOG member and fellow. You can, in fact, after you complete 3 years as a fellow, you can start training programs at your own hospital. Young fellows can avail the travel fellowship. Senior professors can, only who are fellows can become visiting professors, and you can become a faculty in ICOG, CME's ICOG sessions, or even Dr. C.L. Javeri Symposium. And all this is possible only if you are a fellow. And how do you become a fellow? The procedure is very, very simple. It's just a click away. You need to visit the ICOG website. So the next convocation will be during the AICOG in Mumbai, where our team will be installed. But the next opportunity to become a fellow and attend convocation will be at Pune, and you can apply till the 15th of February and attend the ICOG conference and the convocation on the 1st of March 2025. There are specific criteria for becoming a fellow. So you should be having a postgraduate degree in OBGYN at least for 10 years, membership of any Foxy Society for 5 years. We would prefer you to have a publication of 3 papers or articles in Foxy Focus. But if you don't have a publication, and that's a challenge for people in the private sector, you can gather 100 ICOG credit points over a span of 3 years, and it's not difficult, let me tell you. Attendance of 2 Foxy sponsored conferences in 10 years is important, and we would want you to be a faculty in any of the Foxy, FIGO, AOFOC, or even state level conferences, or you should have presented a paper as the first author in any of the Foxy conferences. After you submit all these documents online, the documents are verified by the ICOG staff, and once the fellowship is approved, you will be sent a payment link on which you have to make an online payment. For youngsters, we do have membership, so they can become member. Of course, we are still working on a mechanism on how a young MICOG can become a fellow. So hopefully soon we will come out with a solution. If there are any queries related to ICOG, we are just an email away. So don't forget to email us on icog@foxy.org or icogoffice@gmail.com. And for all the web-based activities which you have missed, you can visit the ICOG website and listen to the lectures or even the training programs that is going on. And I take this opportunity to invite you all to Pune for the 10th ICOG annual conference on updates in OBGYN on the 1st and 2nd of March 2025. So thank you very much. And once again, I appreciate Dr. Charmila and Dr. Madhumita, who coordinated wonderfully well all the three programs for the Tamil Nadu societies. Thank you very much.
Thank you so much for that elaborate
Thank you, Dr. Parag
information on
Vinay, sir.
ICOG activities, sir. I
Madhu,
request
Madhu,
Pratik sir and
Madhu,
Tamil
please
Selvi
answer.
ma'am
Yeah.
to give your comments, sir.
Thank you very much, Dr. Parag Vinay, sir, for taking us through the entire gamut of the ICOJ activities, how the organization was conceived, and how it has grown over the years, over the decades, thanks to contribution of so many eminent seniors, excellent as well as it's always wonderful to be here in the ICOJ platform. Thank you very much, Dr. Charmila, for having me here, and Dr. Madhumita for coordinating. Thank you again for this opportunity.
Thank you, Pratik.
I'd like to welcome Dr. Uma Maheshwari from Virudhunagar Society. I think Madam has joined, as well as Dr. Selvarani from Dindigal Society. Madhu, Tamil Chelvi, would you like to say something before we go on to the next talk?
We can move on because it
Yeah.
is a learning one and we learned many things from Sir today. And everyone should become the FICOG. Try to become members. Thank you.
Trichy has got a huge number of fellows.
Huge number. Yes.
On
Yes,
to
sir. Yeah.
second session. It's my pleasure to introduce the chairpersons for the second session. Dr. Chakravarti, who is the president of Kanjipuram Obstetric and Gynecological Society, and Dr. Uma Maheshwari, who is the secretary of Virudhunagar, who's the president of Virudhunagar Obstetric and Gynecological Society. Uma ma'am? Uma
Yes,
Maheshwari ma'am?
madam. Good evening, madam. Good evening,
Good
madam.
evening.
Am I audible, madam?
Yes, yes, you're
yes,
audible,
yes,
madam. Yes, please.
I request you to introduce our speaker for second session, Raki Singh ma'am.
Yes, madam. I'm actually good evening to all. It's a very pleasant session. I'm actually very much honored to introduce Dr. Rakshi Dhawan Singh. She is holding the post President NOGS, Vice President of UP State. These are here for reviewer for Journals of Obstetrics and Gynecology of India, chairperson for of Endocrinology Society, awards and achievements and publications, invited faculty for almost 350 national and international conferences, Foxy DC Datta Award for publication of hepatitis B in women, Foxy DS Don First Prize at 65 ASUG 2023, written chapters in books Foxy Focus and Jeffcott Gynecology, Fibroid Management, ISAR Express, and Dilemmas in IUI, Yearbook of Obstetrics, GCPR, Wonder Foxian Award, and DERA Award, and IOCUG Appreciation Award. Madam, welcome, madam, welcome. We are all waiting for your presentation, madam. Good evening, madam.
Good evening. Thank you, ma'am. At the outset, I would like to thank Dr. Parul, Dr. Charmila, Dr. Parag sir, and all the chairpersons for being there and inviting me for today's webinar. And it is one of the very important webinars what we are having over here. And understanding of our working of ICOG is very important. And with that, we know what we are doing at ICOG and how you can become a member. That is something very important. And today we're going to talk on prolactinomas and strategic management. How do we do it? As we all do the prolactin hormone levels, we estimate that levels very often. And why do we do it, and where and how much we need to do it? And we all know that the peak level is between 4 a.m. and 6 a.m. in the morning, and circulating half-life of this prolactin hormone is 50 minutes. Prolactin level always rises after the conception period and falls postpartum after, but rises again with every suckling episode of the baby and returns to normal within 4 to 6 months of delivery, even with a continued nursing. There is definitely a role of prolactin inhibiting factors and the prolactin releasing factors. The inhibiting prolactin factors get triggered with the stress, the drugs we intake, and the CNS diseases, pituitary stalk lesions, or any of the surgeries, the cervical spine lesions, herpes, or chronic renal failures. And the stimulation of the prolactin releasing factor can be because of hypothyroidism, or it can be because of the increase in the prolactin production or the pituitary, non-pituitary tumors, or it could be just an idiopathic reason for the galacturia to happen. Hyperprolactinemia, there are various causes which can be there. Either it could be just the physiological ones like the pregnancy or the post-lactation period, the fluctuating hormone levels in the puberty and the menopause, the neonatal exposure to the maternal hormones in utero can produce gynecomastia and galacturia, which is very fondly also called as witch's milk, and the nipple stimulation or the suckling reflex also can cause that. And the non-physiological causes could be the idiopathic hyperprolactinemia to the tune of 40%. Prolactinomas are the tumors where the prolactin level are usually very high. In the cases, the tumor can cause hypersecretion of the prolactin. And there are also other causes like the hypersecretions of prolactin due to the Addison's disease, the acromegaly, Cushing's disease, or infections like tuberculosis or other infections. And prolactin, to move ahead, there are various drugs which cause the raise in the prolactin hormone. Either it could be the antipsychotic drugs the patient is on, or the typical neuropeptides, or the antidepressants that the patient is taking, or drugs for the H2 antagonist if the patient is taking, like cimetidine or ranitidine, or antihypertensives, contraceptives. There are various other domperidone or metoclopramide, or various other drugs like digoxin, spironolactone. There are various so many drugs. And the drug history is very important for the to be elicited from the patient, that if the prolactin hormone is increased, we need to ask the patient that what all drugs the patient is taking. And the systemic disorders also do increase the hyperprolactinemia, like the chronic kidney diseases, because in chronic kidney diseases, usually the clearance is not done that effectively. So there is accumulation of the prolactin levels, and thus it increases the liver failures, hypothyroidism, or epileptic seizures, the chest wall lesions or the irritation, the breast surgeries, pituitary stalk infiltration or the interruptions due to the infiltrative diseases or the tumors. When we are talking about the prolactinomas, they are the prolactin secreting tumors and are commonest hormone secreting tumors of the pituitary gland. Prolactinomas, which are less than 1 centimeter in size, are known as the microprolactinomas, having prolactin level of more than 200 nanograms per ml, or the prolactinomas of the size more than 1 centimeter can be called as the macroprolactinomas and have the prolactin secretion levels of more than 1,000. And non-prolactin secreting tumors and infiltrating disorders of the pituitary stalk hypothalamus can also be seen. These tumors can cause hyperprolactinemia by the disrupting the follow-up of dopamine from the hypothalamus to the anterior pituitary by compressing the pituitary stalks. And this disruption results in decreasing inhibition of the prolactin and results in mild hyperprolactinemia, usually less than 200 nanograms per ml. There are non-hypothalamic pituitary causes, which could be the hypothalamus because of the elevated levels of thyroid releasing factors. The hypothyroid can stimulate the lactophores and resulting in hyperprolactinemia or galacturia. The renal failure, as mentioned, because of the renal clearances is not happening. The chest lesion due to the burns, the surgeries, the herpes zoster can be the cause for the non-hypothalamic reasons. It can also be idiopathic with no known cause, which can be reported for an increase in hyperprolactinemia. And normally in 1/3 of the cases, it resolves on its own and stabilizes the patient. Several medication can cause hyperprolactinemia and galacturia in most instances. The level of the prolactin is less than 200 nanograms per ml. And there are various drugs, as mentioned earlier, which contribute to increase in the prolactin levels. So the history is very important to be elicited from the patient. And it is important to distinguish the secretions that result from the intrinsic breast diseases from the true galacturia of these patients. How to differentiate? The galacturia is defined as a non-purpureal secretions of milk and can be confirmed, if necessary, by the visualizing fat droplets in secretion, usually using low power under the microscope. And galacturia, a word another further, it is isolated galacturia with normal menses and normal serum prolactin level has been estimated up to 20% of the women at some point or the other in their life. And we need to measure serum prolactin level in all the patient. It is not always there that if galacturia is there, it will get self-limiting and it will get corrected, but do measure the prolactin levels also. Hyperprolactinemia is present in 15% of all anovulatory patients and 20% of the women with amenorrhea of undetermined causes and 70% of all women with galacturia have hyperprolactinemia. And 90% of the women with galacturia, amenorrhea, and low estrogen levels have hyperprolactinemias. And we need to evaluate all the galacturia patients by sending the HCG, beta HCG levels, the prolactin levels, the thyroid stimulating hormone, the TSH, and the blood urea nitrogen and creatine levels. If the prolactin levels are very high, alarmingly high, more than 75 or 50. And in those conditions where TSH is normal or abnormal, please, if the TSH is abnormal, replace it by the TSH dopamine drugs. And if the thyroid stimulating hormones and the prolactin level is more than 20, then again, if it is untreated, then please do get an MRI done if the reading is more than 50 or so. And use of MRI. MRI is useful to differentiate between the drug-induced hyperprolactinemia that due to the pituitary tumors. Consultation with a neurologist is important and a neurosurgeon is indicated above 100 according to the guidelines. But we do get patients of prolactinomas having more than 75 or 50 also at times. So be vigilant if she's having other visual disturbances. Please get her MRI done at say 50 or 75 also. It is always worthwhile to note that 3T MRI machines with 1 mm stellar cut provides a very high chance of diagnosing microadenomas with hetero may be missed by earlier generation machines and or more than 2 mm stellar cuts. A word about the prolactinomas. More than 10% of the general populations have undiagnosed prolactinomas. Majority of the prolactinomas are microadenomas, less than 1 centimeter in size. The natural progression of the micro or the macroadenomas are less than 7%. Macroadenomas is responsible for the pseudo hyperprolactinemia and is a common pitfall for the prolactin hormone to be increased. As we all know, after ruling out the breast pathologies, therapies, direction is towards the cause of the hyperprolactinemia. And once the cause is known, then we need to treat the pituitary lesions with the hypogonadism with the problematic galacturia. If not troublesome, it may be monitored without the therapy at times if the prolactin hormone is normal. And the mainstay of hyperprolactinemia is treatment with dopamine agonist, which act on the D2 receptors present on the lactophores and inhibits the prolactin production. In cases where the medication induced hyperprolactinemia, the offending medication should be stopped or changed to a different class of dopamine agonist. In these instances has associated with the slight risk of exacerbation of the psychiatric disorders in most of the patients. And normal prolactin galacturia occurs when the galacturia accompanies normal prolactin levels. If the symptomatic with troublesome galacturia or menstrual cycle irregularities, it can be treated with a medication like the dopamine agonist to obtain symptomatic relief. The treatment is tapered off once the galacturia is resolved. Capgolin is preferred drug of choice and shown to be effectively towards the prolactin level to decrease the size of the tumors also. And it should be continued for at least 2 years in continuation if the tumor size is quite big, and the treatment of galacturia is not necessary if trophic hormone levels are normal and the patient has minimal symptoms. We can go away without the medication also. Prolactin inhibitors like bromocriptine and capgolin, they are the two drugs what are fondly used for the treatment. The mainstay for the hyperprolactinemia is the treatment with bromocriptine or capgolin. The dosage for the bromocriptine is 2.5 to 15 milligram daily, and capgolin we can give from 0.25 to 1 milligram twice weekly. Usually 0.25 is enough for the treatment, once a week or twice a week at the maximum. Bromocriptine, though, can be used for the longest. Let's understand about both the drugs, what side effects and effects are there further on. If the prolactinoma is causing optic nerve compression and is not relieved by the medication, then surgery is advocated, or the radiation therapy or the combination of these two is required for the treatment if it is the symptoms are not relieved. Here we understand that bromocriptine and capgolin, both of the drugs are equally effective and given. The only difference is bromocriptine is to be given daily, whereas capgolin is to be given twice a week or once a week, and the dosage. And there are various side effects of bromocriptine which are little edge above when compared to the capgolin, like the adverse effects, like the nausea is quite high, the headache symptoms are there, and dizziness is quite high, vomiting sensation is very high. That is why patient doesn't prefers bromocriptine, which has to be taken daily. However, considering safety outcomes, capgolin provides to be the safest drug. Thus, the therapeutic choice, considering the results obtained, favors capgolin in the first line of treatment for hyperprolactinemia. A word about infertility and hyperprolactinemia. Mild to moderate hyperprolactinemia is a frequent finding in young women presenting with infertility. Mildly elevated prolactin levels may cause luteal phase insufficiency in the cycling woman, that is a regular cycle woman, and associated with recurrent miscarriages. Preference is given to capgolin at a lowest possible dose that normalizes the prolactin, restoring fertility in the majority of the cases. Capgolin achieved a very high rate of success rate up to the tune of 94%. And that is why that is a drug of choice for the infertile patients, and a long-term history of amenorrhea in women with at least 35 years. Pregnancy is also achieved very easily with that. There was another study which had 20 prospective women with hyperprolactinemia and infertility. Both of them were treated with oral capgolin twice a week for 4 weeks, and the serum prolactin level was measured thereafter, and the ovulation induction did happen, and a successful conception was documented by the transvaginal ultrasound. And the study shows the effectiveness of capgolin therapy both on lowering the serum prolactin levels and successful conception with no major side effects which were measured. And when we talk about the prospective study, another one which was done in 2022 and with approximately 900 female patients, and the groups were divided equally into capgolin group and the bromocriptine group. And post the study, capgolin is an effective drug for the spontaneous conception within 6 months of successful restoration of menstruation and female patient with prolactinomas. Live birth rate is also high in capgolin group as compared to bromocriptine group. There is also an association of hyperprolactinemia with hyperandrogenism, as the studies have said since the ages and decades. From 1976 to 2018, there are various studies which reveal that prevalence of hyperprolactinemia in PCOS women in the literature over the time, that there is an association, and approximately 28% of the women have it. Some studies have suggested that the dopamine can also slow down the secretion of the LH, and it has thus been hypothesized that the high level of LH found in PCO women would be secondary to a decrease in dopaminergic tone, and that would be responsible for an increase in the prolactin levels. And when we talk about this study in 2021, the prevalence of a polycystic ovarian syndrome in association with circulating gonadotrophins and the prolactin, the survey study, the hormonal reports of 100 patients stated that the increase in the prolactin levels cause ovulatory dysfunction ranging from the short luteal phase to anovulatory cycles to the amenorrhea, hypogonadism, and presents to the extent of gonadotrophin secretion. And this study states that the PCO infertile woman must be assessed for the serum prolactin level as well as the other clinical or the pathological examinations to confirm the actual cause of coexisting of these two disorders. The points to remember: rule out any of the other breast diseases which are available. If we can find out, identify and treat the cause. Treatment of hypothyroidism needs to be done if we have seen it is there, and the treatment of hyperprolactinemia needs to be given. 70% of the women with hyperprolactinemia, galacturia, and amenorrhea with low estrogen levels have a prolactinoma. Women with regular menses, galacturia, and normal prolactin levels do not have prolactinomas. About 13% of the women with prolactinomas do not have galacturia. And galacturia is a non-lactational production of the milk. Galacturia could be the sign of an underlying problem, so a thorough investigation is required. Most common cause of galacturia is hyperprolactinemia. The condition is often managed by multidisciplinary involvement by the team of gynecologists, radiologists, endocrinologists, neurosurgeon if the levels are quite high. And the detailed medication history may prove important to clue for the diagnosis for the causes which can be triggering factor for the patient. And about 3 to 5% of the individuals have hypothyroidism in association, and thyroid level to be measured in all the patients with hyperprolactinemia. We do want to remember that not all hyperprolactinemia patients present with galacturia, but galacturia can be seen with normal prolactin levels also. Thank you all. At the outset, I would like to request all of you that I'm standing for Vice Presidency, Foxy, from North Zone, and seek your blessings for the same.
Thank you, Raki. There are actually two questions, and
Yeah.
One is by Dr. Chellappan sir, and he has asked, as a general obstetrician, when do we involve endocrinologists in hyperprolactinemia, or should we involve neurologists?
As a general obstetrician, hyperprolactinemia we can treat on our own. But if the hyperprolactinemia levels are above 75 or so, 50 or 75, 50 with the symptoms of the pain in the eyes, compression symptoms, headache symptoms, very severe, then from then onwards, or from 75 onwards, if the patient is not getting relieved of the symptoms, and if the patient is not getting relieved by the levels coming down with the capgolin measurement and any other pathologies which are available.
Dr. Sandhya is asking, a patient has got galacturia, hyperprolactinemia, but normal MRI. How long should bromocriptine be continued once the symptoms have improved?
I would prefer capgolin more than the bromocriptine, as the studies I have quoted also. Capgolin gives much better result and a much better way to remove it. And sometimes it is idiopathic also. And capgolin weekly once 0.25, there is no other symptoms, no other history. If the patient is giving a history of drug intake, sometimes patients do take other drugs and then they think that it is a normal to take those drugs, and they are not. And like the antacids what the patient is taking, ranitidine or pan-DSR or something of that sort, and the patient thinks that it is normal to take all that, pantosids and all that, and then they don't reveal. We need to ask in detail the drug history or the homeopathic drug if the patient is taking, which can be the precursor for all the prolactin hormones. Or just in foul pain, the nipple stimulation could also be one part of it.
Yeah. And if an infertile patient has been put on cabergoline and she conceives, should it be continued or stopped? And that's a question by Dr. Rita Malik.
if the patient is put on capgolin, and if the levels of the prolactin hormone were quite high, above the 100 levels or 200, and the microprolactinomas were seen, or the macroprolactinomas were seen, then the dosage is continued in conjunction with the endocrinologist, because those high levels are normally dealt with the endocrinologist in play. And in those high levels, it is continued for say about first 3 months, and then it gets settled, and then taper it down, and then we can stop it.
Thank you, Raki. I think we'll take up the other questions after the third talk. So,
Yeah.
Madhu, you can introduce the chairpersons for the third talk of Dr.
Yes,
Manisha.
ma'am.
Thank you, Charmila, and thank you, ICOG, and thank you, one and all the chairpersons, Pratik, Umila, and everybody. Thank you.
Thank you, Raki.
Thank you, ma'am. So moving on to the third session, can I have the series slides, please? Nilima, can you display the CV slides? Okay, moving on to the third session. Nilima? Okay. So for the third session, we have our three eminent chairpersons with us. Dr. Amla Devi, who's the president of Dindikal Obstetric and Gynecological Society. Next, please. Dr. Umayal Murugesan, who's secretary of Kanjipuram Obstetric and Gynecological Society. And we have Dr. Uma Velmurugan, who's the secretary of Trichy Obstetric and Gynecological Society. Umayal ma'am, is there?
Yes.
Uma ma'am,
Good evening.
request you to please.
Yeah,
Yes, ma'am. Hello, ma'am.
Hello.
Uma ma'am, request you to please introduce our third speaker, Dr. Manisha Beg, ma'am.
Yeah, Dr. Manisha is a well-known figure in Tamil Nadu, and she's a great orator herself. She is from Christian Medical College, Vellore, and she's got trained at Wellington Regional Center for Maternal and Fetal Medicine, Wellington, New Zealand, and
thank you, ma'am. I think that's enough. I think we'll go on to the thing. Can I start?
yeah. So all the best, and yes, looking forward to your talk.
Okay. Is my screen visible?
Manisha, it's visible. Yeah.
It is visible.
Okay.
It is visible.
Yes, ma'am.
At the outset, I would really like to thank ICOG, especially Dr. Charmila, Dr. Parag, and Dr. Madhumita for giving me this opportunity to be able to speak in this esteemed forum. I know you guys are doing an amazing job with the academics of ICOG. So my talk, it's slightly different from what we generally present. So I thought I will talk about biomarkers of predicting adverse pregnancy outcomes. So after that, vivid talk by Dr. Raki on hyperprolactinemia, it's slightly something different, but it is something that will give us food of thought, because now as obstetricians, we encounter more and more pregnancies where women are high risk, have multiple complicating factors, and they do tend to have adverse pregnancy outcomes. Then how can we predict these? How can we stop these? And what are the long-term implications of adverse pregnancy outcomes? So first of all, this is the plan. The presentation is going to be very simple. So we talk about the biomarkers. So we know that there are different kind of biomarkers that are used in medicine. Some of them are for monitoring, some of them are for prediction, some of them for safety, susceptibility risk, etc., so on and so forth. In pregnancy, the biomarkers that we use are usually called the predictive biomarkers, and they are basically for predicting adverse pregnancy outcomes, which can be seen in 30% of our pregnant women. Now, these biomarkers, they have different sources. So you can get some of these biomarkers which are produced by placenta. Some of these are biomarkers which can predict endothelial dysfunction and angiogenic imbalance. Some of them which can predict end organ damage. And these are different types. Various types have been used. Some of them have used proteins, some of them have used metabolites, DNA, RNA, etc. The most common ones that we are using are basically proteins and hormones. Now, why adverse pregnancy outcomes? Now, we know that adverse pregnancy outcomes are seen in 30% of our pregnant women. These are essentially hypertension or preeclampsia, gestational diabetes, fetal growth restriction, intrauterine fetal demise, preterm birth. Now, these pregnancy outcomes have three things in common actually. All of these are characterized by placental ischemia, maternal inflammation, and vascular dysfunction. So these three are the common pathways for all of these adverse pregnancy outcomes. Now, why are we talking about adverse pregnancy outcomes? Now, it is very important for us to sensitize ourselves as to the relationship between adverse pregnancy outcomes and long-term cardiovascular disease in a woman. Because long-term cardiovascular disease in a woman and adverse pregnancy outcomes, they have the same underlying pathology. And adverse pregnancy outcomes in pregnancy actually uncover a woman's predisposition for having premature cardiovascular disease. Gestational hypertension and preeclampsia, for example, increase the risk of coronary artery disease and heart failure and stroke by 2 to 4-fold. And the highest risk is seen in women who have recurrent preeclampsias, in recurrent pregnancies if they have preeclampsia. Similarly, things like gestational diabetes, which we see so commonly in our OPDs, increase twofold risk of type 2 diabetes mellitus in these women, and also increase the risk of cardiovascular disease independent of diabetes mellitus by twofold in our women. Similarly, preterm birth increase the risk of cardiovascular disease or heart failure by 1.4 to 2-fold. So these are some of the figures that we need to actually think about and ponder as we see our women in our obstetric clinics with having hypertension and gestational diabetes, preterm births, preeclampsias, that these not only have imminent danger to the woman and her baby, but also have long-term sequelae in terms of maternal health. Now, this is a very interesting paper that I would actually recommend all of you to read. It was published in the European Cardiology Review in 2021, and it actually pointed out what is known as the fourth trimester and how pregnancy is a predictor of cardiovascular disease. So again, as we said, the three things, the vascular dysfunction, the placental ischemia, maternal inflammation kind of expose the woman to long-term cardiovascular sequelae. So there will be some pre-existing risk factors, but once the woman has all these complications in pregnancy, actually that pushes her towards a definite end result where the cardiovascular diseases can occur. So these are some of the important things that we need to keep in mind. Now, actually, this was a guideline that was in 2018, it was recommended by American College of Cardiology and American Heart Association. This was brought forth in 2018, where they recognized that adverse pregnancy outcomes are actually risk enhancers of long-term cardiovascular disease in women. So what they did was they recommended the use of statins in women with borderline or intermediate risk of cardiovascular disease who had adverse pregnancy outcomes during their pregnancies. So such weightage they gave to adverse pregnancy outcomes is that if a woman, even though if she is a borderline or an intermediate risk for cardiovascular disease, but she had an adverse pregnancy outcome in her pregnancy, that actually pushes her towards the high risk, and therefore she needed to be started on statins. So this is something that we need to think about as well. Now, coming to prediction of adverse, so how can we predict? Now we are saying that adverse pregnancy outcomes are important for us, important for our women because they have long-term implications. Can we predict them in the first trimester? Now we are very well aware of this slide, this paper which was published by Kypros Nikolaidis in 2011 in Fetal Diagnosis and Therapy, where he was talking about inverting the pyramid of care. So in the traditional pyramid of care, if you see the first visit, and then the subsequent visits, and the maximum number of visits are towards the end of the pregnancy from 37, 38 weeks and so on and so forth. Whereas when you invert the pyramid of care, you see the maximum weightage is given to the first visit, that's the 12-week. And then actually, if you do a very good job there, you will actually be able to cut down on your subsequent visits because you have been able to recognize the risk factors, deal with them, and do prevention strategies to prevent those complications. So that concept is known as inverting the pyramid of care. And this kind of changed the paradigm of antenatal care after this paper was published in 2011. Now, coming back to our biomarkers, most of the biomarkers that we use in pregnancy are actually secreted by placenta, and they kind of promote angiogenesis. I will be talking in details about these. They regulate maternal metabolism during pregnancy. Their levels are altered in various pathologic conditions, and therefore we are able to identify them. And by picking up these biomarkers, there is an early recognition of high-risk pregnancies, which can lead to enhanced antepartum surveillance and therefore improved pregnancy outcomes. So first we talk about screening for aneuploidy. Now, when we talk about screening for aneuploidy, we know that we use markers in the first trimester. The biochemical markers that we use are PAPE, pregnancy-associated plasma protein A and beta-HCG. And in second trimester, we use 4 markers: inhibin, unconjugated estriol, alpha-fetoprotein, and HCG. So these are used along with your maternal characteristic, that is maternal age, then your scan findings, and then these biomarkers are combined together to give a risk of aneuploidy for each pregnant woman. So you will get a report something like this. This is a report that I have taken. Now, what I want you to see is the red highlighted area. So we generally see the risk of Down syndrome, we see the risk of trisomy 18 and 13, but let's not just stop there. Let's look at the biomarkers too. So if you see that the red area, the free beta HCG and the PAPE, now these have story to tell as well. Apart from the aneuploidy risk that is there is much more information that we can get out of these biomarkers. And what are these information? Now, this is the RCOG guidelines on prediction of SGA and FGR, basically investigation and care for a small for gestational age baby. And this paper, it clearly showed that when you have a PAP-A value of less than 0.4 multiples of median, AFP value, which is more than 2 multiples of median, inhibin, which is more than 2 multiples of median, these are all predictive of a small for gestational age baby or a fetal growth restricted baby. So this is very important for us to remember. So apart from the detection of the aneuploidy, it is also giving us what is there a possibility of this baby having SGA or FGR. In fact, it is important to know that PAPE value less than 0.4 MOM is actually an independent risk factor for SGA and FGR. And it is also an independent risk factor for stillbirths due to uteroplacental insufficiency. So next time when we see a combined first trimester screening report, we should also focus on the biomarkers apart from the risk for aneuploidy. So that is something that we must remember. So how does this PAPE work? Why is PAPE an independent risk factor? So this PAPE is actually a proteolytic enzyme. It kind of proteolyzes the insulin-like growth factor binding protein. So when it proteolyzes that, what happens is the insulin-like growth factor is freed from its binding protein. And when it is freed from the binding protein, it can act on its receptor and bring about the fetal growth. So if you have a low PAPE, then what happens? This insulin-like growth factor will not be freed from its binding protein and its bound form is inactive. So if the bound form is inactive, then obviously you don't have the insulin-like growth factor for the baby to grow. And that is how PAPE independently can cause SGA or FGR, because it causes the insulin-like growth factor in its bound or inactive form to increase. Now coming to another important biomarker, that is beta-HCG. We are all very well aware that it is derived from syncytial trophoblast. We are all very well aware it's a glycoprotein. We also know that it's a promoter of early fetal development and it has role in implantation and establishment of maternal fetal circulation. Now, what is important is this paper, which has recently been published in 2024. Actually, it's a meta-analysis which looked at the association between human chorionic gonadotrophin and adverse pregnancy outcomes. So they looked at several studies. They actually looked at around 182 studies involving thousands and thousands of women, and they looked at what MOM of HCG can we predict various adverse pregnancy outcomes, namely SGA, preeclampsia, preterm birth, gestational diabetes. So two important things came out of it is that within beta HCG MOM more than 3, the odds ratio of having a small for gestational age baby increased by 2. And the risk for preeclampsia with a beta HCG MOM of 3 increased to 3. So those are very important findings that we need to know. So again, these things have to be taken into account when we are reading our combined first trimester screening report. So this was the overall conclusion of the study. So when we have a low first trimester HCG level, that increases the risk of intrauterine fetal demise less than 24 weeks. But what happens when we have a high HCG level? High HCG level, both in first and second trimester screening, if we look at, if we do the aneuploidy screening, both first and second trimester screening have increased HCG levels. And both of these, if they have increased HCG levels, then it can point towards preeclampsia, especially if the baby is not aneuploid. And second thing is that increased HCG levels in the second trimester is also a risk, is also a biomarker for stillbirths. Now, why this increased HCG? You would think that HCG is a pro-pregnancy hormone. Therefore, the more pro-pregnancy hormone, the better the outcome. But actually, what they have seen is that increased HCG levels is suggestive of poor placentation, secondary to inflammation and vascular dysregulation. And they also tried to look at the association between HCG levels and preterm birth, gestational diabetes, and abruption, and they could not find any significant association. So the two most important things were preeclampsia, stillbirths, and small for gestational age babies. Now, again, the question is whether we should look for what is known as hyperglycosylated HCG or whether we should look for total HCG. So most of our essays are looking at the total beta HCG. Now, hyperglycosylated HCG is something that is specifically involved in implantation through the invasion of uterine wall and musculature. Therefore, there is a speculation that if we are able to measure this proportion of hyperglycosylated HCG out of the total HCG, then it will be a better prediction for hypertension and fetal growth restriction in the subsequent gestational weeks. So that is something that is in the okay. Now coming for prediction of preeclampsia and associated complications. Now all of us as obstetricians dread this complication of preeclampsia because of this so much of maternal morbidity and sometimes mortality that is associated with it. You can name any dreaded complication, whether it is HELP or abruption or eclampsia, sometimes fetal growth restriction and intrauterine fetal demise. All of these are sequelae of preeclampsia. Now, most of these occur in nulliparous women and they are without risk factors. In developing countries, 30% of these are early onset preeclampsias and 70% are late onset preeclampsias. So this is the thing that I took from the FIGO website actually. So it talks about the burden of preeclampsia. So we know that around 76,000 women die of preeclampsia each year, and the most common cause of death due to preeclampsia is intracranial hemorrhage. And around 500,000 babies die each year from preeclampsia. So actually the burden, if you see, it is, although it seems to affect 2 to 5% of pregnant women and in some countries 8 to 12%, especially in the African continent, so to say. But actually, if you look at the overall global burden, it's quite a bit. So actually what FIGO recommends is that universal screening for preterm preeclampsia should be done in all pregnant women using the triple test. Now, what is this triple test? Okay, before I talk about the triple test, I would like to talk about this 3-stage model in the pathogenesis of preeclampsia, which is a very important concept for us to understand. Now, we know that in a normal pregnancy, what happens is there is normal remodeling of the uterine artery. So the trophoblastic invasion into the spiral arterioles, which are end arteries of the uterine artery, is such that you have a very low resistance feto-placental system which is established. That is the normal. Now, if you have a low resistance feto-placental system, placenta is well perfused because it is receiving adequate blood supply from the maternal circulation. Placenta is well oxygenated, and a well perfused, well oxygenated placenta is going to produce what is known as placental growth factor. And then this placental growth factor acts on what is called vascular endothelial growth factor, and these actually lead to formation of healthy endothelium, and therefore the pregnancy is normal. Now, in a pregnancy which is affected with preeclampsia, the stage 1, that is the remodeling of the uterine artery itself is defective. So there is defective trophoblastic invasion of this uterine artery. Then stage 2 is it leads to placental hypoperfusion. So if there is placental hypoperfusion, the placenta has having oxidative damage. Now, instead of producing the pro-angiogenic factor, that is placental growth factor, it starts producing anti-angiogenic, that is S-FLIT. Now, this S-FLIT is supposed to inhibit the vascular endothelial growth factor, and therefore you have damaged endothelium. Now, when you have damaged endothelium, then all the consequences, whether it is eclampsia, whether it is HELP or proteinuria or pulmonary edema or FGR, all of these can be caused by this damaged endothelium. So this 3-stage model is important for us to remember. Stage 1, that is uterine artery remodeling. Stage 2, that is hypoperfusion or hyperperfusion of placenta. And stage 3, that is damaged endothelium. Now, coming to screening for preeclampsia, so this is what the Fetal Medicine Foundation in UK model is, where they look at the medical history and maternal characteristics. Medical history would include the age of the woman, the interpregnancy interval, the type of conception, the type of pregnancy, whether it is singleton or multiple, whether previous history of preeclampsia, whether family history of preeclampsia, so on and so forth. So there is a huge list of maternal medical history. And then they look at uterine artery Doppler. So the mean pulsatility index of the uterine artery Doppler is looked for. And if that is more than 95th centile or whatever it is, whether it is less or more, if it is more than 95th centile, it is definitely abnormal. So you have to record that. And then you have to look at the PLGF concentration. If it is less than the 5th centile for the gestational age, it is definitely abnormal. So combining all these three together, there is actually an FMF calculator where you can feed in all your information, and then you get a risk factor. So you also have to measure the mean arterial blood pressure. All this is done at the end of the first trimester. So all this risk estimation is at the end of the first trimester. Now, how good it is in predicting? It can pick up early preeclampsia less than 34 weeks to the tune of almost 76 to 80%, which is quite good. Late preeclampsia, the detection rate is not very high. It's around 46%. So we must remember that early onset preeclampsia is what we are targeting, and it's around 80%. So this is how the calculator on the FMF website, if you go, it looks like. So what is the type of pregnancy? How much is the crown ramp length? One examination date, height, weight, BMI, smoking history, etc. Then what is the mean arterial pressure? What is the mean uterine PI? And what is your level of PLGF? If you don't have PLGF, then even PAPE you can do. So these are the things that you incorporate into your calculator, and then you press calculate risk. It will give you the risk of preeclampsia. Now, any risk which is greater than 1 in 100 is abnormal. So why do you have to predict? Does prediction help? Of course it helps, because we know about this landmark trial called the Aspirate trial, which was published in NEGM in 2017. We know that when the risk was more than 1 in 100 and these women was started into low-dose aspirin tablets, they found out that there was almost an 82% drop in the rate of preeclampsia and associated fetal growth restriction along with it. So therefore, you have a prediction model, and you also have a prevention strategy. Therefore, the prediction model is likely to be helpful. If you don't have something to prevent, then there is no point in predicting if you don't have a treatment. Now, coming to prediction of late preeclampsia. Now, this is a bit of a challenge because our FMF model is only able to predict 46% of the cases. So in late preeclampsia, there is something else that we use. So we use the concept of angiogenic imbalance. Now, if you remember the first slide that I had put about the 3-stage pathogenesis of preeclampsia, we said the pro-angiogenic is the PLGF and the anti-angiogenic is the S-FLIT. Now, so in the prediction of late preeclampsia, what we do is we look at the ratio of the pro and the anti-angiogenic. Actually, it's the other way around, anti-angiogenic and the pro-angiogenic factors. Okay. So we must remember that angiogenic imbalance is the hallmark of preeclampsia. So in a normal pregnancy, you will have more of PLGF and less of S-FLIT. And in a preeclamptic pregnancy, you have less of PLGF, that is pro-angiogenic, and more of S-FLIT. And it's very important to remember that S-FLIT is also increased in women with atherosclerosis. So here we have the connection with cardiovascular disease, coronary artery disease. So all these are actually interlinked to each other. So actually, this was the paper which was published in December 2022 in Archives of Gynecology and Obstetrics, and the authors have actually put together an algorithm which is like a traffic light algorithm, so to say, to manage and predict late preeclampsia. So if you have, so what they look at is the ratio of the S-FLIT and PLGF. Now, if this ratio is less than 38, then you are in the green zone. That actually rules out preeclampsia, and therefore that has a very high negative predictive value. You just need to follow up the woman in 4 weeks. Now, if you have a value between 38 to 85, that is when you are in the orange zone or the yellow zone. These are where you may not have. Now, we must remember that all these predictors have a good negative predictive value. They can rule out a disease confidently, but ruling in is something where the positive predictive value falls. So here there is an orange zone. So therefore, it is recommended to follow up in 1 week. Now, if the value of S-FLIT bar and PLGF ratio is more than 85, then there is definitely preeclampsia and impending adverse outcomes. So this sensitivity and specificity is quite good. Sensitivity of around 90% and specificity of 99%. So actually, these are the women you need close surveillance and hospitalization. Now, I'll tell you in which situation, in which clinical scenarios you can use. Sometimes we are not very sure whether it is preeclampsia or not. I know in common practice, you would generally see women who come to you, and preeclampsia diagnosis might be very straightforward. You don't really need to use all this to diagnose preeclampsia. You have a high blood pressure, you have proteinuria, you have your biochemical parameters, which tell you, okay, this is preeclampsia. Now, there are a certain subset of women, for example, women who have got SLE or who have got an underlying renal pathology. Now, these women also will have proteinuria. These women also might have high blood pressure. And these women also will have their kidney function test deranged and all those things. So actually, those are the cases that you may have some ambiguity in diagnosis, whether it is really a placental insufficiency or whether it is just a worsening of the SLE or just a worsening of the lupus nephritis or whatever kidney disease that is. So in such cases, using this ratio will actually help us predict and will actually help us in diagnosing preeclampsia and taking care of it and not confusing with the other diagnosis. Now, having talked about the complications which constitute majority of our obstetric practice, let's talk about preterm birth. Now, we know that preterm birth is defined as birth between 24 to 37 weeks. 10% of all our births are preterm. According to the World Health Organization, 50 million preterm births occur every year. 1 million babies die due to prematurity each year, and 70% of neonatal deaths are due to preterm and preterm morbidity. Now, fetal fibronectin is one biomarker that has been used for diagnosis of preterm labor. Now, what is fetal fibronectin? It's actually an adhesive glycoprotein that is present in the maternal fetal interface. So maternal interface is the uterine wall and the fetal interface is your chorioamnion. So it is a glycoprotein which actually acts like a glue between your uterine wall and your chorioamniotic membranes. Now, what is important to remember is that it should not be present in the cervicovaginal secretions between 24 to 37 weeks in a normal situation. So if you find that these cervicovaginal secretions have fetal fibronectin, it indicates that there is an inflammatory damage and there is a mechanical damage to the fetal membranes, which is a hallmark of preterm birth. Now, again, as with all the biomarkers, this biomarker also has a very good negative predictive value. So if it is not found in the cervicovaginal secretions, then the possibility that the woman will deliver because of preterm delivery is in the next 7 to 10 days is very low. So the negative predictive value is much higher. So it rules out preterm birth, but it cannot rule in preterm delivery. So that is important to remember. And also we must remember that it should be used in conjunction with your other clinical characteristics. For example, cervical length measurement, it has a higher sensitivity. If a woman has come with some symptoms, and then you should not use these things just for screening in low risk women, just to see how they are performing. So all these biomarkers have a greater sensitivity and are more relevant if you are combining them with the use of maternal characteristics and other clinical characteristics. So this is again, as I told you, that fetal fibronectin, it acts as a glue between your chorioamniotic membranes and your uterine wall. And that is the kit that is used for detection of fetal fibronectin. Also, you must make sure that the woman has not had sexual intercourse, because sexual intercourse again can lead to presence of fetal fibronectin in cervicovaginal secretions. Now, there are a lot of biomarkers which have been used in these lot of studies, but actually none of them have been proven to be so useful. So you can see the corticotrophin releasing hormone, VEGF, alpha fetoprotein, HCG, relaxin, PAPE, MMPs and all that. But some of these require further studies. Most of them, there is insufficient data or they are not very specific. One thing, of course, this study was done by Thomas G. et al., and this was published in American Journal of Obstetrics and Gynecology, MFM series in 2023, where they combined actually PAPE, they combined HCG, and they also combined maternal serum alpha fetoprotein, because in US, they have a combination of contingent screening for aneuploidies. They will do first trimester and second trimester, so they will use a whole lot of biomarkers. So they have studied these women who underwent these screenings, and they used PAPE and beta HCG from the first trimester and MSAFP from the second trimester, and they found out that combining first trimester markers and second trimester markers increased the sensitivity of prediction for preterm delivery by to 63% and low birth weight by 69%. So this is just a study that was published by these people. So coming to what are the take-home messages at the end of this presentation, I hope I have been able to sensitize us as to saying that adverse pregnancy outcomes increase the risk of long-term cardiovascular disease in our women, and therefore we need to warn them about it, about the follow-up, long-term follow-up and postpartum, especially evaluation after the baby is born, because that is the time when they are not going to come back to us, and we are not able to follow up what happens to them unless they are pregnant again. So we need to talk to them about, look, there is a risk because you had this outcome. There is a long-term risk of cardiovascular disease. If she's at gestational diabetes, make sure that they are doing their sugar check every once in a year. If they have been hypertensive, make sure they are following up with a physician just to make sure that the blood pressures are normal. They get an ECG echo done and make sure that they are on routine follow-up. Another important thing to remember is sensitivity and specificity increases when we use these biomarkers in combination with maternal history, clinical characteristics. So these are not to be used alone. These are to be used in conjunction. First and second trimester markers for aneuploidy can predict small for gestational age and preeclampsia also. So when we look at a combined first trimester screening report or a second trimester quadruple marker, please don't just stop looking at the aneuploidy risk, also focus on the biomarkers is the message I want to give today. Serum PLGF levels and S-FLIT PLGF ratio is useful for prediction of early onset. It's more for a late onset preeclampsia really. And fetal fibronectin has a strong negative predictive value to rule out preterm birth. Thank you so much for a patient listening.
That was a very nice, well-spoken talk. And though the topic was little dry, you made it very, very interesting with beautiful explanations and lovely presentation.
Thank you.
Thank you. Thank you for that wonderful
Thank you, Umayya. Uma, can you?
Yeah, I just wanted to add up. It was like, for me, I felt like it was like a revision course, starting from first trimester and going on, and how would you care about the patient postnatally as well. So that was a very, very beautiful presentation, Manisha. I think you took so much efforts to put all these together. I thoroughly enjoyed it. It's just that as if I was a postgraduate sitting in a classroom and then listening to all these beautiful things. Thank you very much.
Yeah, actually, I was thinking the same. That
Oh,
it
yeah,
was like
yes,
attending a
it's
class in CMC Vellore.
It was absolutely like a class.
It was very much up to the point and superb. I enjoyed listening to it and I could not leave it.
Pratik wants to say something. Yeah.
Explained every bit and point of it. Everybody must have really loved it.
We enjoyed the academic feast actually.
Yeah.
Yeah, definitely. It was an academic feast to
Yeah,
hear to us.
fit ICOG session today. Wonderful
Yeah,
session.
that was very nice, Manisha. Very nice, Dr. Shobha Gudi here.
Thank you.
Pratik wants to say something. Pratik.
So fantastic program today. Excellent academics. Beautiful talks by all three speakers. Evidence-based talks by Raki as well as the minister. And I'm sure the audience will have benefited immensely from your well-researched presentations and the excellent evidence-based both of you presented. Thank you very much for making me a part of this, Dr. Karmila.
Thank you, Pratik. Before we go on to the discussion with Manisha, there are two more questions for Dr. Raki. Dr. Sandhya has asked, can be continued if microadenoma is seen, and we need to follow up based on symptoms and continue if the patient is symptomatic. We cannot rely on serum prolactin levels once pregnant. I think that is acceptable, right? What she is saying is, once she becomes pregnant, you cannot follow up a microadenoma with
Definitely, we cannot do the serum prolactin levels and all that. But depending upon the size and the previous treatment, we need to continue it.
And Dr. Vijayashri Seshatri has asked, what is your opinion on association of recurrent miscarriages and microprolactinemia?
As I had mentioned earlier, also recurrent miscarriages are little on the higher end, depending upon the prolactin levels. If it is quite high, then definitely it affects the luteal phase insufficiency, and the implantation failures are also very common over there.
And, Dr. Dhanalakshmi has asked, a 38-year-old having a microadenoma for 4 years, but has no symptoms, only prolactin level more than 110, and if the patient is on cabergoline, prolactin levels are normal. Once cabergoline is stopped, again the levels increase to 80 to 90. But when she is asymptomatic, why do you want to do anything?
No, but prolactin levels, if they are high, she should be put up on the medication, because otherwise it will microadenoma. You never know when it gets triggered and get converted into the macroadenomas. It's much better to, because
how long will you give the drug and how do you follow up?
It's a serum prolactin levels have to be measured, no? If she is not pregnant, and once she's pregnancy, because it has been there and the history has been noted that the prolactin level was responding to it, and once we stop, it is increasing the levels. So definitely you need to continue it. That itself says that it's a dependent tumor.
Okay, thank you. Lots of congratulatory messages for Manisha. Dr. Parag has said, excellent lecture. Tamil Chelvi has said, a fantastic Manisha. Dr. Sandhya has said, excellent presentation. Dr. Neerja has thanked you for the excellent presentation. Dr. Raki has said, a very informative lecture. There's one question from Dr. Chellappan Karpaya, sir, and he's asking, when do you suggest the use of PLGF SFLT1 at how many weeks in routine practice?
Thank you for that question, sir. Actually, that S-FLIT PLGF ratio is exclusively for second and third trimester. It's not for first trimester. When you have a doubt whether it is preeclampsia, like in setup like ours in medical college, we see a lot of SLE patients. We see a lot of people with lupus nephritis. And sometimes when they have a flare also, they can have worsening proteinuria, they will have high blood pressure. So you're often in doubt whether, whether it is actually preeclampsia or whether it's just a flare. So because the treatments are different. So that is the time when this ratio can actually help in. So it's essentially for second and third trimester.
Not for a routine practice.
Not for a routine practice.
Routine practice, yes.
Yeah.
How much it is costing, Charmila? No, I wanted to know in her setting.
We don't get such cases, Manisha, but there is, it's chargeable at the college, no? So they will not know, I think. Anybody else is doing?
I'll have to find, yeah.
No. Madam, I think 1,500, 2,000, something like that. That's what I heard once. I think Revati was talking on that once. And,
yeah, there will be a little kind of challenge in interpreting it, is what I'm thinking, for management. So wanted to ask Manisha that how does she act on a kind of raised level?
The values are less than 40. Actually, there are clear-cut guidelines to say that it is not preeclampsia. That a lot of these papers from Leona Poon and all, if you see when she's talked about that. So that is cutoff is roughly around 40. So if it is less than, so again, as I said, ruling in is more difficult. Ruling out is easier for all these biomarkers. So if you have a value which is less than 40, you can confidently rule out it's not that. That is one.
And Dr. Vijayalakshmi Seshatri has asked, excellent lecture. And are we doing fetal fibronectin? Are you doing in CMC Vellore?
We were doing till some time back, but I think we ran out of stock and now we are not doing anymore.
Oh.
Yeah.
Was it useful?
But again,
Was
for
it
ruling
Was it useful is the question, really.
Was it useful?
Because it has been given up is what I understood,
Yes,
because
yes,
it
yes. So
doesn't
now it is no
change
longer
much.
being used. For the sake of completion, I did add. What I will tell you is this is something that will not be used in all settings. But in a setting like ours, where we have a very busy labor room and we have some patient who has come with some niggling pains and you don't really know whether it is preterm labor, whether she's likely to go into preterm labor, you know, those kind of things. And you would want to say, okay, can we shift her out? Can we discharge her? So those are the things. Again, as I said, these biomarkers as for ruling out and not for ruling in. So those
I
kind
think
of
what we used to kind of interpret it as is when to give the steroids and not to give unnecessary steroid and not to admit.
So definitely that's a very relevant usage, because you don't want to give them, load them with steroids when it is not indicated. And again, Maxelf, as you know, is rampantly being used left, right, and center. So these are some of the things where it might help in management. But of course, now it is not being used. Just to complete the list I had actually.
Correct.
Shobha Madam has said it's a very well prepared lecture. Dr. Shaini has said an excellent presentation. And Dr. Chellappan sir has asked, like, we discuss and practice a lot of aneuploidy screening, wherein the incidence is around 1 in 800, whereas incidence of FGR in our country is around 30%. Do you suggest any specific strategy for FGR screening in our country?
Actually, one thing that, as you have very rightly put into perspective, that we are so hyped about aneuploidy screening. But that itself, you know, when you look at the markers, like when you look at the risk, okay, this is the risk of Down syndrome. Let's not stop there. It itself has got PAPE and other things. And if you have a PAPE value of less than 0.4, that itself is a risk factor for SGA. That is one thing. Then second thing is, previously how we were doing, we were basing it on basis of maternal history and all those things. Now this FMF calculator has come where they look at maternal blood pressure, look at uterine artery PI, look at PAPE, and they give you a risk of early onset preeclampsia, which is essentially always associated with FGR. So these two go hand in hand. But what is available for us in a busy OPD, when you're seeing 200, 300 patients in an OPD like us, we can't do uterine artery PI for everybody, to be very honest. We do check blood pressure of all our women. That is something that we have. And aneuploidy screening is something that most of our women would opt for. So then in that case, we just look at the PAPE value and see whether it is in the normal range, it is in the abnormal range. Of course, if your baby has aneuploidy, then you can explain why PAPE is abnormal. But if your baby has got normal chromosomes, then that PAPE has no business to be less than 0.4. That means there is definitely some underlying uteroplacental insufficiency. So that is something that needs to be highlighted. The woman needs to be followed up more carefully and started on aspirin.
Yeah, that is, Charmila, if you'll permit me, one question I have been wanting to ask obstetricians from Vellore because of your high obstetric load. Do you have a high-risk pregnancy clinic separately? Do you have?
All their pregnancies are high risk.
Unfortunately, no, ma'am, because all our pregnancies will be high risk. So we are seeing high risk ratio of 70s to 30s.
Yeah. Tamil Nadu dumps its high risk cases
actually,
to
it solves the problem for you. So, but for us, we do get low risk gravidas, no? So I just wanted to know if you're running, and if you are running, then how is it running and all that.
Pratik, mute yourself, please. And then Dr. Tamil Selvi Naveen is asking, can we start low molecular weight heparin if the uterine artery PI remains high even after starting aspirin? Actually, you should not follow up with uterine artery PI. It's not necessary. Once you have checked.
So once you have started aspirin, that should take care of the thing. Uterine heparin should not be used unless the woman is associated to have APLA. That is a very clear-cut indication. If there's a bad obstetric history, early onset uteroplacental insufficiency with an APLA positive, that is a definite indication for heparin. But in the absence of APLA, just because uterine artery PI is high, aspirin alone is sufficient. There is no need for any other medications to be given.
And,
what is your experience in APLA negative RPL, where you find, you know?
We label it as seronegative APLA.
That's a very controversial area. Again, there is no clear-cut consensus whether we should give heparin or not. I mean, We take this case by case basis in discussion with our rheumatologist. Frankly, we also don't have a clear-cut guideline on this, unfortunately.
Both Dr. Jayabharati and Tamil Sri said that the test cost 6,000 rupees. So that is your answer for the amount, Shobha madam. And Dr.
Yeah,
Claudia
even
just
I
said,
thought it was 5,000 because that is what I thought. So we actually hesitate to do that. So I was asking.
Yeah.
And
So it is not to be done in routine settings. And again, as I said, there are very specific indications for doing those actually.
and it's worthwhile. If you want to wait on a patient with severe preeclampsia and you want to wait for the baby's maturity, it's worthwhile doing it 6,000. That
Yes,
should not be a cost factor at that point.
It is worth.
Worth
Yeah.
it.
And
And
especially because all these women with SLE, lupus nephritis, they will have only one chance of pregnancy. So terminating at the drop of a hat, sometimes it's not, we have to be very careful, weigh our decisions very careful when we say terminate pregnancy. And invariably they would have had miscarriages, they would have prolonged periods of infertility. So it's a very careful decision making that has to be done. And this is one of the tools I feel which will help us in decision making.
Yeah,
Raki, there's a
because there
question
are
for you
some
from
proponents, Charmila, of preeclampsia screening who are very vociferously advocating it for, picking up preeclampsia within it is as a predictor that within the next 5 weeks you will have severe disease.
Yes.
And then, that is what is the common message given. So I think needs to be revised to what has been discussed today. I think this is a more practical approach for low resource
Yeah, so
setting
any
like India.
biomarkers should not be, as ma'am clearly said, Dr. Shobha, I don't think any biomarker should be used independently in a low risk woman. It has to be used in context in the relevant setting. That is very important. Let's not forget the clinical setting in which we are.
Clinical settings.
Yes.
There's one question for Raki, and that's by Dr. Chellappan Karpaya, sir. And he's asked, how will you investigate galactoria at puberty in a 12-year-old girl? Raki, please unmute us.
You're muted, ma'am.
Galactoria in 12-year-old, we need to check for any foul play, any nipple stimulations. At time, the kids are also having that urge to do that. And if there is any other drug intake history, and prolactin level definitely has to be checked. Ask for the visual impairment symptoms if the patient is having any. Because 12-year-old will not have the breast development to that extent that galacturia should set in. There has to be some pathology.
I was
more
a
to it.
little surprised. I have not seen galactoria in such young.
Madam,
There has
sometimes
to
they
be
come
some
with
pathology
complaints.
more to it because breast development doesn't happen to its full form at that age.
But patients complain sometimes that some fluid is coming and all that. And Dr. Chellappan has asked Dr. Manisha, now that the concept of fourth trimester is coming in, would it be wise to add cholesterol with lipid profiles in our antenatal patients? Incidence of dyslipidemia is also high in our country. And would it be useful to roll out CBD in future? That's definite. We have to add.
Yeah, definitely. But we generally don't do lipid profile and all those in pregnancy. But fourth trimester is the concept when you have the women in the postpartum period, not to miss this window of opportunity to do all these screenings, including lipid profile, family assessment of cardiovascular disease, and to keep them in so that they're not lost to follow up. So that paper that I actually presented, that European Cardiology Review, that's a very beautiful paper. Actually, I can put it up in the group. I think it's a must read it's an eye opener. Even I was not aware of, such high risks associated with adverse pregnancy outcomes.
Who is the author, Manisha, for that?
Somebody called Penee, Penee.
Oh, Penee. Okay.
Penee.
Penee.
Penee. Very beautifully written.
Nick Penee. It must be Nick Penee.
I think we have crossed our time limit of almost by 40 minutes.
Must
so I
be
think
Nick
we'll wrap
Penee.
it up.
Yeah.
I think we'll wrap it up. Dr. Shobha and Dr. Manisha, you can talk in the next webinar. We'll be calling
We'll do that.
both of you.
We'll do that, Charmila. For sure, we'll do that.
Parag, would you like to say something before we close it?
Yes. So thank you very much, everyone. We hope that this webinar would go on for 1 hour, and it's, as Charmila said, it is almost 100 minutes. Manisha lecture was fantastic. I think, Charmila, we should have such lectures time and again, because it is something which is a doable thing.
Yeah.
So sometimes I'm tempted to prescribe aspirin to each and every woman that comes, and just as the representative of the Justice organization, will endorse it. Thank you, Rakhi, for being here.
Thank
Our
you, sir.
passion about endocrinology is something which we always notice. And thank you, everyone, all the president secretaries of the Tamil Nadu societies. And again, thank you, Charmila and Madhu, for doing a brilliant job. And we'll see you soon in such program. Shobha, the next turn is yours for the Karnataka and Kerala societies. You can take Madhu's help, you can take Charmila's help, and of course, Rakhi, for you, it is the North Society.
I'm ready to go up with the
Yes,
Shobha.
we'll start from the first week of Jan, and then we'll just carry it. Thank you very much.
Sure, sure. Okay.
Thank you, Parag sir, and Charmila for the opportunity.
Thank you.
Madhu, vote of thanks.
Yes.
And thank Neelima, we forgot to welcome her.
So, concluding this wonderful webinar, first and foremost, I would like to thank Parag sir and Charmila ma'am for bringing us this series of 3 wonderful webinars of Tamil Nadu societies. I thank our Foxy office bearers, Dr. Jaydeep Frank, Dr. Parul sir, Dr. Madhuri Patel ma'am, Dr. Sheila Mani ma'am, and Dr. Sarita ma'am for the blessings and support always. I would like to thank our esteemed speakers, Parag sir, Dr. Rakhi Singh ma'am, and Dr. Manisha Beck, and our chairpersons, Dr. Pratik Tambe sir, Dr. Tamil Chelvi ma'am, Dr. Tamil Mani ma'am, Dr. Chakravarti sir, Dr. Uma Maheshwari ma'am, Dr. Amla Devi ma'am, Dr. Umayal ma'am, and Dr. Uma Vel Murugan ma'am for your expert opinion and comments. I would like to thank all the presidents and secretaries of the societies of Trichy, Vellore, Tanjavur, Virudunagar, Kanjipuram, and Dindigul for the active participation in this webinar. And I would also like to thank all the delegates who are present here and for your active participation. And a big thank you to Neelima and the ICOG team for the technical support offered. Thank you all once again.
Thank you, Madhu. Thank you so much for a beautiful coordination.
Thank you so much. Thank you.